Sir is an MD CFM degree holder from AIIMS Rishikesh and currently a consultant physician in GBR Hospital, Narsarapeta. He is an executive member of Indian Forum for Medical Research and State Best NSS Volunteer Award. We are glad to have you here, sir. Welcome, sir.
Thank you, Karthikeyan. Actually, I would like to add some few points which were told by Dr. Preeti. Actually, the concept of community and family medicine came after the establishment of the newly formed AIIMS. Okay, what they want to do was, instead of just community medicine, they want to have a comprehensive branch. Okay, in earlier days, it is like the general physician used to treat, and if there is any need, the patients are going to specialists, whether it is general medicine or neurology, cardiology, or anything. But that concept of having a referral system was lacking. Okay, just to so the government has thought, the Ministry of Family Welfare and Health has thought that there needs to be a comprehensive system which will enable the presently upcoming physicians to give a comprehensive healthcare to the patients. Okay, this is the main concept behind community and family medicine, and this is not a new concept. Okay, it is not a new concept. Many other countries already have this community and family medicine in force, and some other countries have community medicine separately and family medicine separately. Ultimately, the goal of this branch was to get a comprehensive specialist so that he can give the primary care and he can refer the patient whenever it is necessary. So that is the concept of community and family medicine. Just to replenish the previous family physicians, they don't have a separate degree as family physicians, but we do have some doctors, our family doctor. So nowadays the concept is going away. So to have that idea of a family doctor, so instead of the family doctor, we are getting family physicians. So what is the difference between family medicine and community and family medicine is,
Sir, I think you are muted, sir. Dr. Kranthi Kumar, sir, I think you are muted, sir.
I'm sorry, I just got a call. Okay. So the thing is, you have the preventive part, which is not that much taught in family medicine. In family medicine, preventive medicine has a single paper only. Okay, and you are having, along with that, we are having the family medicine part also. Okay, so the syllabus for family medicine was entirely covered by us. Along with that, we are having the community medicine also. So what we have a benefit here is, we were told much about the programs, much about the vaccinations, much about the research methodologies, and along with that, we are studying the family medicine by entering our OPDs, running our family medicine OPDs, and having posting in the other departments, super specialty departments and specialty departments and subspecialty departments. So we are getting an upper hand with that. Okay, I don't know about the other people's curriculum, but at AIIMS Rishikesh, for our batch we have posting for entirely 1 year of posting in the other departments, specialty, super specialty, and subspecialty branches. And then for the entire 3 years, we are running the family medicine OPD, and the peripheral centers OPD were also run by the PG students. So we got a lot of exposure in seeing the patients in general as a general physician, and with subspecialty and super specialty posting, we got an idea when to refer and where to refer a patient. Okay, first the concept is, if you're a family physician, the main thing which you should know is whether the patient can be treated by you or not. If he can be treated by you, till how much you can treat that patient, means what is the severity, up to which severity you can treat that patient, and then you should know when you should refer that patient also, and where should you refer that patient. It is not like you got a patient which is who is having CVA, and you have treated him up to the chronic stage. If there is an acute onset of the chronic CVA, then it is not like that we will just send that patient to a general physician and then he will send it to a neurologist. So how you should learn is whether I should send this patient to a general means internal medicine fellow, or should I send this patient directly to the neurologist fellow. Another concept is if the patient is having seizures. So whether you should differentiate whether it is a organic cause or a psychological cause, and then you should send the patient to a psychiatrist or a neurophysician. So that level of competency you should achieve. Then only you can practice like a family physician. If you don't know and you are just referring the patient just like that, thinking that this is not my case, then I can send this patient to some other one. Whether it would be a general medicine fellow or a neurosurgeon, neurophysician, or a oncologist, it should not be like that. Your concept you should not be a transit point. You should be the person who is deciding. You should not be the person who is transiting, bypassing. You should be the person who is deciding, okay, this patient will go to neurophysician. After that, after the acute phase is finishing, he should come to me and he should counsel the patient like that only. Okay, for this condition, I am referring it to you. After that, please come back to me. I will decide. Means if you are telling the patient like this, then he will get a confidence in you. Okay, this doctor knows what to do and how should it go. And so it is better for me to come back to him. After getting the treatment, it is better for me to come back to him so that he can guide me better. So you should give the patient that much of confidence that, yes, my guy knows everything about me and he knows everything about the treatment. So your competency should be growing in such direction. And some of the, if you are looking for the opportunities in community medicine, so this is the dual benefit. If you are doing only family medicine, you will be this family physician. For our degree, that is community and family medicine, the other benefit is if you want to enter into the programs, you can directly enter into them. Means your orientation should be in that way. Either you want to become a family physician or a community and family physician. So if you want to become a community physician or a preventive care specialist, then make sure that your direction is in that way. Because you can't put your legs on two boats simultaneously. So if you want to become a community physician or a program manager, ensure that your direction is in that only. So your thesis should be in that way, so that the person who want to employ you should know that, yes, this person know about something about public health and this person is useful to you. Your research publication should be in that way only. Okay, like in programs or in preventive aspects or innovative ideas in in improving the healthcare. So your research prospect should also be in that way only, so that your career will be molded towards that way. And if you felt bored or if you felt that no, I can't do this, then you can shift into the family medicine prospect with some training and with some guidance from your seniors or from the consultants. So it is a dual benefit to all of us.